You've been taking this pill every single morning for years. Your doctor checked your TSH, it came back normal. Nobody said anything about your bones. You did everything right. You got the diagnosis, you filled the prescription, you kept every appointment. And every time, the lab report looked fine. Nobody sat down and explained that normal TSH and no bone loss are not the same thing. A collaboration between Johns Hopkins and the National Institute on Aging, using data from the Baltimore Longitudinal Study of Aging, found that levothyroxine use was associated with significantly greater bone mass and density loss in adults over 65, even in participants whose TSH levels were within the normal range. The median follow-up, 6.3 years. The finding held even after controlling for age, BMI, and other medications. In this video, I'm going to walk you through exactly what the research found, why a normal TSH may not be enough to protect your bones, and the one question you should bring to your next appointment. This box, right here. If you're over 60 and you've been diagnosed with hypothyroidism, there's a good chance something that looks exactly like this is on your counter every morning. You take it before breakfast, you've been taking it for years, your doctor checks your TSH, it comes back in range, and the appointment ends. Nothing else is said. I'm James Reyes. I'm not a physician, I'm a researcher, and I want to be clear about that, because nothing in this video is medical advice. What I'm about to show you is what the research says and what most clinical appointments don't have time to discuss. My father spent years going through a system that looked at each problem separately and missed the picture as a whole. I learned the hard way that being informed is not optional. That's why I do this work. Before we go any further, drop a comment right now with where you're from, just your state or country. I want to know who's watching, because what I'm about to walk you through matters differently depending on how long you've been on this medication. Here's what most women are told when they're prescribed levothyroxine. Take it every morning on an empty stomach, get your TSH checked every 6 to 12 months, and if it's in range, you're fine.
That's the protocol. That's what the guidelines say. And in most cases, that's where the conversation ends. What the conversation doesn't include, and what a research team at Johns Hopkins and the National Institute on Aging just documented, is what may be happening to your bones while that protocol is running exactly as intended. The study used data from the Baltimore Longitudinal Study of Aging, one of the longest-running aging research programs in the United States, operated by the National Institute on Aging. It's not a short-term study. It's not a survey. It's prospective data collected over years from real community-dwelling adults living their lives. They looked specifically at adults over 65, all of them with TSH levels within the normal reference range. Some were on levothyroxine, some weren't. Everything else, age, BMI, other medications, smoking history, was controlled for. The result? Women and men on levothyroxine showed significantly greater loss of total body bone mass and bone density over the follow-up period. Significantly. And the median follow-up was 6.3 years. Have you ever had a bone density scan? And if not, has anyone ever explained why it might matter while you're on this medication? That number, 6.3 years, matters because that's not a side effect that shows up fast. It's not something you feel in month 1. It's quiet, it's cumulative, and by the time it becomes visible on an X-ray, the loss has already been building for years. I want to say something carefully here. This study, and I'll be precise about this, was presented at the 2024 annual meeting of the Radiological Society of North America. It has not yet been published in a peer-reviewed journal. That distinction matters. What it shows is a signal, a significant, controlled, longitudinally documented signal, not a final verdict, not a reason to stop your medication, but a reason, a serious one, to understand what's being monitored and what isn't. In the next section, I'm going to explain exactly why a normal TSH may not be telling the whole story about what the hormone is doing at the cellular level, especially in bones.
And there's a mechanism behind this finding, one that researchers have been documenting in smaller studies for years, and that the Johns Hopkins team is now describing at a scale that changes how we should be thinking about long-term levothyroxine use. That's where we're going next. Let me explain what TSH actually measures and why that matters more than most people realize. TSH stands for thyroid stimulating hormone. It's produced by your pituitary gland, and its job is to tell your thyroid to make more or less thyroid hormone. When TSH is in the normal range, the standard interpretation is your thyroid hormone levels are adequate. Your pituitary is not asking for more. The system looks balanced. Think of it like a thermostat. The thermostat reads the room temperature and turns the furnace on or off. When the room is warm enough, the thermostat stops signaling. But here's the thing about a thermostat. It can only measure what it was designed to measure. It reads the air. It doesn't know what's happening to the pipes. What levothyroxine does is add T4 from outside that loop. Your thyroid isn't producing it. The pill is. The TSH comes down, the pituitary stops signaling, and on paper everything looks regulated. But here's the question the Johns Hopkins team was asking. What is that circulating T4 actually doing in tissues where it's active and where normal TSH doesn't measure its effects? Bone is one of those tissues. Thyroid hormone, specifically T3, which is the active form converted from T4, has direct receptors in bone cells. It influences the balance between osteoblasts, which build bone, and osteoclasts, which break it down. When there's excess thyroid hormone, even at levels that still read as within range on a TSH test, the balance tips. Resorption accelerates. The bone loses density faster than it rebuilds it. This is not a new concern. Studies going back decades have documented elevated bone loss in patients on suppressive doses of levothyroxine, doses high enough to push TSH below normal. What the BLSA study adds is something different. The finding that even therapeutic doses that keep TSH within range, may be associated with this effect in older adults. Within range, still losing bone. That distinction between we suppressed your TSH and your TSH is normal but you're still on the medication is the distinction most clinical guidelines haven't caught up to yet. And there's a second layer to this that I think is equally important, and that gets far less attention. Levothyroxine is one of the most commonly prescribed medications in the United States. Estimates suggest that somewhere between 30 and 54% of people newly started on this medication may have normal thyroid function, meaning the original diagnosis may have been made based on TSH levels that, for an older adult, are actually within a healthy age-adjusted range. Not the standard range, the age-adjusted range. Here's what that looks like in practice. A woman in her late 60s goes in for a routine physical. Her TSH comes back slightly elevated, just above the standard upper limit. Her doctor, following current guidelines, diagnoses subclinical hypothyroidism and prescribes levothyroxine, standard of care. What neither of them knew, because most labs don't use age-adjusted ranges, is that TSH levels tend to rise naturally with age. That slightly elevated reading may have been completely normal for her age, not pathological, not requiring treatment. She leaves with a prescription she may not have needed. And that prescription, if the BLSA finding holds, is associated with progressive bone loss she didn't know to watch for. Here's why that matters for this conversation. If a significant proportion of women over 60 are taking levothyroxine for a diagnosis that may have been made using a reference range that doesn't account for normal age-related shifts in TSH,
then those women may be receiving a medication that is, by the BLSA finding, associated with progressive bone loss for a condition they may not actually have in the clinically meaningful sense. That's not a fringe argument. That was the subject of a plenary presentation at the American Thyroid Association annual meeting in 2024. Do you know whether your hypothyroid diagnosis was based on a single TSH reading and whether your doctor mentioned age-adjusted reference ranges? I'm not saying every woman on this medication is overmedicated. I'm saying the evidence now supports asking the question, and that the bone implications of not asking it are documented in a longitudinal study in a controlled cohort over 6 years. In the next section, I want to look at what the research says about who is at most risk and what the data shows about postmenopausal women specifically, because there's a compounding factor that the BLSA study and the thyroid literature both point to, and it's one that affects postmenopausal women in a way that makes this finding specifically relevant to you. That's next. Postmenopausal women are already operating with a structural disadvantage when it comes to bone density. After menopause, estrogen levels drop, and estrogen is one of the primary regulators of bone remodeling in women. It slows the activity of osteoclasts. It keeps the breakdown process in check. When estrogen falls, that break loosens, bone loss accelerates. This is why osteoporosis disproportionately affects women after 60. It's not just age, it's the interaction between age and the hormonal shift that came before it. Write this down. Now add levothyroxine to that picture. If the mechanism documented in the BLSA study is accurate, thyroid hormone directly stimulating bone resorption even at TSH normal doses, then women who are both postmenopausal and on long-term levothyroxine are potentially facing two separate, simultaneous processes pushing in the same direction. Not one risk, two, running at the same time in the same tissue. The literature on suppressive levothyroxine therapy and postmenopausal women using doses that brought TSH below normal has documented this compounding effect for years. What the BLSA study suggests is that the threshold for concern may be lower than previously assumed. So what should women who are on levothyroxine and postmenopausal actually be doing? The evidence points toward one concrete step: bone density monitoring. A DEXA scan, dual energy X-ray absorptometry, is the clinical standard for measuring bone mineral density. It's non-invasive, takes about 15 minutes, and gives your doctor a T-score that tells you where your bone density stands relative to a reference population. Let me explain what that T-score means, because it's the number that determines everything that follows. A T-score of 0 means your bone density is average for a healthy young adult. A score between -1 and -2.5 means you're in the osteopenia range, lower than normal, but not yet at the fracture risk threshold. Below -2.5 is the clinical definition of osteoporosis. Most women over 65 who haven't been screened have no idea where they fall on that scale. And women on levothyroxine have an additional specific reason, documented now in a controlled longitudinal study, to find out. Current guidelines already recommend DEXA screening for all women 65 and older. What the BLSA finding adds is a specific rationale for women on levothyroxine to discuss with their physician whether more frequent monitoring is warranted. Not just a baseline, but an active longitudinal picture, not once, repeated, so you can see the trajectory, not just the number. And this is where I want to be direct with you. The medical system is not ignoring this. The conversation is happening at Johns Hopkins, at the American Thyroid Association, in the literature on subclinical hypothyroidism treatment in older adults. But it's happening at the level of the system that doesn't automatically translate into what gets said at a 15-minute appointment. My father's doctors weren't ignoring him either. They were working within a system that wasn't designed to see what the research was starting to show. The gap between what the evidence documents and what arrives at a clinical appointment, that gap is real, and it's the gap this channel exists to close. If you've been on levothyroxine for more than 3 years, do you know when you last had a DEXA scan and whether your doctor connected those two things? In the next section, I want to give you the specific framework, the questions, the language, the exact conversation to have with your doctor so that you walk into your next appointment with something concrete. Because the research has done its job, the signal is documented. What happens next depends on the conversation you have in that room, and I want to make sure you know exactly what to say. Let me give you 3 things you can do with what you just learned. The first is a question, not a confrontation, a question.
The next time you're with your prescribing physician, ask this exactly. Given that I'm postmenopausal and have been on levothyroxine for a number of years, should we add a DEXA scan to my regular monitoring? And do you want to review whether my current dose is the right one for my age? That's it. That's the ask. It does 2 things. It opens the bone monitoring conversation, and it signals that you know there's a connection worth evaluating. You're not challenging your doctor. You're giving them information that may not have come up in a routine 12-minute appointment. That's different. And most physicians, when a patient brings a specific, sourced, informed question, will engage with it. The second is context. If your doctor says your TSH is normal, there's nothing to review, you now have the language to respond. You can say, I came across a study from Johns Hopkins and the National Institute on Aging that found bone loss was associated with levothyroxine even in patients with normal TSH levels. I'm not asking you to change anything today. I'm asking whether it's worth adding a DEXA to keep an eye on this over time. That's not a challenge. That's informed participation. That's what being your own advocate looks like. And if your doctor is unfamiliar with the BLSA study, which was only presented at a radiology conference in 2024, that's an opening, not a wall. You can say it was presented at the RSNA meeting in November 2024 by researchers at Johns Hopkins. I can bring you the abstract if that would be helpful. That sentence alone changes the entire dynamic of the appointment. The third is a reminder, and this one matters. This video is not a reason to stop your medication. Levothyroxine is an important, well-documented treatment for hypothyroidism. For many women, the risks of untreated or undertreated hypothyroidism, cardiovascular effects, fatigue, cognitive changes, outweigh other concerns. That assessment belongs to you and your doctor. What this video is a reason to make sure that assessment is actually happening.
Because the question is not just, is this medication working? The question is everything that should be monitored while I'm on it being monitored? I've sat in enough waiting rooms to know that the answer to that question is often no. Not because the doctor doesn't care, because the system doesn't build in the time to ask it. That's what I want to change. One informed patient at a time, one conversation at a time, one appointment where the right question finally gets asked. If you found this useful, and I mean genuinely useful, not just interesting, please share it with someone who takes this medication, not as an alarm, as information they deserve to have. And if you're new here, I cover what the research shows about women's health after 60, the findings your doctor may not have time to discuss, and the questions that change the conversation. Subscribe and make sure the bell is on, because this kind of information is time-sensitive in a way that matters. Now, here's what I want you to take from this video. The Johns Hopkins and NIA finding isn't a final verdict, it's a signal, a well-controlled, longitudinally documented signal. And signals like this, when you understand them, give you time. Time to ask the question before the loss is visible. Time to get the scan before you're treating a fracture. Thyroid health and bone health are not 2 separate conversations. The research is starting to show they never were. The system just hadn't built a bridge between them. You now know enough to ask for that bridge. One last thing before you go. Leave a comment with this. Are you on levothyroxine? And has anyone ever mentioned your bone density in that same appointment? Yes or no? I want to know how many women are watching this who've never had that conversation, because that number matters and it will inform what I cover next. You took this pill this morning, probably before you even saw this video, and your doctor's notes say your TSH is normal. What they don't say is what that pill may have been quietly doing to your bones for the past 6 years. The question is what you do with that information.